So the first question, would robotic surgery be used for older patients, for example, somebody over the age of 75? And is there a recommended age range?
Can you repeat that?
Can you repeat that?
May I repeat that? The question was, would robotic surgery be used for an older patient, for example, somebody over the age of 75? And is there a recommended age range for robotic surgery?
I'll start off. I think 75, everything is generalization. I think 75 is kind of our unspoken cutoff to say, well, you may want to consider another option besides surgery. So again, it has to be individualized. Not every 75-year-old is the same. I think the oldest patient I've operated on was in his late 70s, but he was he's running the Hawaiian triathlon. So he is healthier than I ever could hope to be. So I'm not sure what my colleagues would do, but I think 75 is just at the boundary of where you would generally consider surgery.
Yeah, I agree. I think it takes just a risk assessment of the patient. Someone who's very healthy and 75 or older may do well from surgery. I do tell patients that when you're older, or if you have diabetes or other health conditions, your risk of incontinence is greater. And so that's, I think, with an informed discussion with your urologist, you can decide if you're 75 or older, if you even want to go through that. But yeah, I think 75 is probably an unspoken limit.
Yeah, I agree as well. I think that things like the Chicago Marathon, the Hawaii Ironman, those are excellent barometers to states of health. So I would agree.
I also think it depends on how aggressive the cancer is.
Yes.
So someone who has a very aggressive cancer but older, I would be more inclined to consider surgery as a part of their treatment process.
Great. Thank you very much. So the next question is, how does perineural invasion affect surgical procedures and their outcomes?
I think that's a good question. Perineural invasion is, and this is intraprostatic perineural invasion, that is typically reported on the biopsies, and it's been shown that is correlated with a higher risk of extraprostatic extension. But I think you have to incorporate not only the biopsy findings, but certainly the MRI and contact length of the tumor, et cetera, in guiding that decision-making process. We've got an interesting study going on at Rush now to see how things like perineural invasion affect the likelihood of being able to safely spare the nerves or not. So more to come on that.
Yeah, I would agree. I think perineural invasion portends a higher risk of local failure, not necessarily widespread metastatic disease, but it's certainly you can. I think it requires more than of local understanding of what that person's cancer wants to do, whether you can feel it, whether MRI shows any growth. That means something that you could see invading the nerves. I think that's more important for me, specifically as relates to sparing the nerves than finding perineural invasion on the biopsy.
Yeah, I agree with both statements. I think there's two places where you can look at perineural invasion. It's on the biopsy specimens, if there's perineural invasion. If you have that, I think, as Dr. Deane stated, looking at all the other clinical parameters is important. I think if you have perineural invasion on the prostatectomy specimen and it's organ confined, some patients may ask, do I need other therapy or do I need to do other things? And I think just surveying with PSA checks is appropriate.
Okay, thank you. So another question now is, for a diagnosed individual, what precautions should their male children consider?
That's a great question. Obviously, genetics does play a role in a man being diagnosed with prostate cancer. It doesn't mean that they're going to get it. It's just a higher risk. So I think that's one of the screening flaws of the screening recommendations. It really doesn't incorporate that. So I certainly, in someone who has a family history, specifically father or brother, I have a much more detailed discussion when offering screening. The thing about it is urologists are not necessarily the ones offering a primary screening test. So sometimes we do because they're seeing us for another reason, and we say, well, okay, now you're 42 and your father had prostate cancer or brother. It also is very important at what age they were diagnosed. So if your father, or well, let's say father specifically, who's a first-degree relative, was diagnosed when he was 55, it's very different in terms of your risk than if he was diagnosed at 85. So I think it's important to consider when you're talking about screening. I think it's important to consider asking and knowing when that first-degree relative was diagnosed.
All right. So another question here. So this is regarding seed implantations, which wasn't discussed, but the question was, do you have any additional opinions on this technique that you might want to share?
So brachytherapy, is that?
Mm-hmm.
No, I think if the question is it effective for treating and curing prostate cancer, that's certainly been proven the case for localized prostate cancer. So just some more information on brachytherapy or seed implant. It's an outpatient procedure, so you go home the same day. You still have the same effects of radiation as if you had external beam. Some people say there might be less of the rectal toxicity and some of the bladder toxicity, but I think as far as for curative intent for prostate cancer, it's an effective therapy.
One of the things that we're seeing is that brachytherapy numbers overall are declining, and I think that is likely directly related to changes in screening practices, whereas in prior years, the patients who were good candidates for brachytherapy tended to be on the lower risk, lower volume disease spectrum, whereas now we're not detecting those so much, especially if we incorporate the tests that predict the probabilities of higher grade tumors being present. Candidates for brachytherapy are being screened out, I think.
All right, thank you. So another question I have here. Is it beneficial to have a prostatectomy after cancer has spread for metastases?
Oh, that's a loaded question. That's a tough one. Hopefully we're going to start a study soon looking at that. There has been data in terms of radiation, in terms of people who got hormones. So oftentimes patients where the cancer has already spread, they'll get hormones only. There has been data suggesting that local therapy, that means treating the prostate in addition to hormone therapy, has been associated, does improve outcomes. We're going to try and start studying that in the surgery group through a multi-institutional cohort study in the near future, we hope. But that is a loaded question. Often it's done as a part of what we call multimodal therapy. I think if you have disease outside the prostate and you've offered them surgery, it's someone who's motivated to do that in a part of not just surgery alone as a part of a treatment plan. But hopefully that'll be answered, but it's going to take some time.
All right, thank you. So question I have here regarding Provenge. Does it extend life? Does it extend outcomes overall compared to other treatments for someone with a stage 4 diagnosis? And what would it compare to some of the other options?
That's also a loaded question because for Provenge therapy in patients with it's only approved for patients with castrate-resistant disease as of now, and the window of opportunity is also a narrow window in the sense that you have to have castrate-resistant disease, so your PSA is rising when your testosterone is low, less than 30, and you have to also have minimal disease that's metastatic. So if you have widespread metastatic disease, lesions, you're not actually a candidate for Provenge. The other thing with Provenge is that your PSA, if it's rising and you're treated with Provenge, your PSA may not necessarily decline. And so the studies that were done on Provenge show improved survival, but not necessarily any sort of biomarker improvement. So that question should definitely be discussed with your oncologist if someone has that question.
Yeah, that's, Provenge has been shown to be effective to improve overall survival, not necessarily prostate-specific survival. So the mechanism by which it works is unclear. But also the patients and doctors like to see results from their treatments. So it's nice to see when a PSA goes down, okay, I feel good about both of us, both us and the patients like to see some improvement. And so Provenge doesn't necessarily offer that. I can say personally, I don't recall having given, again, we don't treat necessarily metastatic patients, but we don't give out a lot of Provenge or recommend a lot of Provenge. But also therapies are becoming, we have more therapies now than we did when Provenge first came out that are effective.
I think also one of the things to acknowledge is that for all immune-based treatment regimens, they're most likely to work when the disease burden is at its smallest. When we start to get to the castrate-resistant metastatic prostate cancer space, that's a large disease burden. You know, so as the other panelists have said, yes, it's going to increase survival by a short amount, but you know, we're left to wonder if it were implemented much earlier, whether the outcomes would be better.
Okay, thank you. So I have a question here regarding fusion biopsies, and the participant was wondering if you could go into more detail about what that is and when it might be used.
Good question. So fusion biopsy is, as you heard Dr. Patel mention earlier, the fusion biopsy really takes a detailed look at the prostate gland with an MRI, which we're then able to transpose and superimpose the images on what we're seeing at the time of biopsy with a real-time ultrasound transrectally. It gives us a target. You know, it literally puts a little red dot on the screen. You know, it's like it's kind of like playing darts right here, as opposed to throwing at the dartboard on the wall. It's pretty easy to hit the red dot, particularly if you take multiple samples around the nice ringtone, by the way. Particularly if you take multiple samples around where you think the volume hotspot is on the MRI. And certainly the chances of detecting the prostate cancers in the first go of biopsies is incrementally higher than with a standard non-MR fusion type biopsy. So I think it's the way to go for initial biopsy and also for repeat biopsy, especially if there's been a prior negative 12-core sample. Yes, there are issues with getting insurance to approve it, and some places have a team that basically discusses the clinical scenarios with the insurance and work really hard to get the MRs approved.
Yeah, I think it definitely has a role, and it'll become more and more important and popular. But I do think because of these insurance issues, oftentimes it's people who've had a negative biopsy and their PSA keeps going up. I think that's, at least right now, where it's becoming more commonplace. It certainly does help. Oftentimes it'll tell you, when you look at it takes an ultrasound and it takes an MRI image and puts it over the ultrasound, because you can't do it, or at least most people don't have the capability of doing a real-time MRI-guided biopsy. So I think it'll be helpful, but it certainly has its place in someone who you're worried may have cancer that you missed.
All right, so if anyone else has thought of any additional questions, I got plenty more cards up here, but if we could have a couple volunteers come around just to collect a few more, if anyone's thought of anything else. In the meantime, I have a couple questions here just regarding Gleason scoring. So a participant was wondering just a little bit about Gleason scoring. They wrote here, for example, a Gleason score of 7, whether that's a 4 and a 3 or a 3 and a 4, is there a difference, and what is that difference?
Yeah, that's a great question. And actually, I can't remember if it was which pathology group, but there's going to be a new criteria for prostate cancer where it's a new grading system. So it's the same Gleason grading system, but they're going to recategorize it And it's going to go from 1 to 5, and 1 is going to be the Gleason 6, 2 is going to be 3 plus 4, 3 is going to be 4 plus 3, and so on and so forth. And the reason they're doing that is because there is a clinical difference, an oncologic difference between the 3 plus 4s and the 4 plus 3s. And as Dr. Kundu presented when he was talking about the Gleason scoring, the main difference is that the first number is what they see the most of, and the second number is what they see the second most of on those specimens. And so with 4 plus 3, there's a higher amount of 4, more high-grade disease that's present.
Yeah, I think the Gleason score is extremely important. It's probably one of the most important things that we look at. So when you say you have prostate cancer and you look at a urologist, I mean, you look at a bunch of different things, but the first thing we'll probably want to know is what is your Gleason score. So it's extraordinarily important to understand what that is, and that tells us whether we need treatment, don't need treatment, and how aggressively we need to be with your treatment.
All right. So another question regarding the Gleason scoring. With time, do Gleason scores change? Do they increase or decrease associated with treatment?
That's an excellent question as well. And the long and short is that yes, the Gleason scores can change. Having said that, one is left to wonder whether, as I had mentioned in my talk, whether there's elements of tumor heterogeneity, meaning that there's a Gleason 3 plus 3 on the biopsy, and then within that tumor there's also pattern 4, which was just missed, but then you get it on the second biopsy, and all of a sudden that triggers the thought process that there's been a change in the grade, when in actual fact the Gleason 4 existed before, it just wasn't sampled. And I think that these are areas that hopefully genetic and genomic markers on the cells will help us to figure out the risk when we see a Gleason 3 plus 3 of there being higher grade disease in that tumor.
Mm-hmm.
Yeah, I think there's no question cancer can progress and does progress. The question is, does the Gleason 6 change or is it a new tumor? And I think it's a combination of both. But there's no question on patients on active surveillance, for example, a fair number will have a worse tumor over time. So Gleason score does change. So if you start off with a 6, you can't just say necessarily, again, that's what I'm going to have for the rest of my life. So it has to be watched. And again, that's very important for us. And how much of it is there is also very important.
All right, thank you. Another question I have here. What areas are most associated with metastases, and would many of them be treated with chemo?
So, prostate cancer can go to a variety of different places: lymph nodes, bone, lung, liver. Generally, once the tumor has spread beyond the prostate, it would be treated with hormone therapy. Now, there's been data from and chemotherapy in general and historically has not been a very effective treatment for prostate cancer, unlike hormones. There has been now some data suggesting that in patients, or actually I shouldn't say suggesting, showing that chemo in addition to hormones at the early stage has been dramatically associated with an improved survival benefit, and that it's regardless of bone and regardless of sites and how much tumor. And in fact, the patients who had the worst tumor burden, meaning what we call high tumor burden, had the greatest benefit in giving a certain chemotherapy called docetaxel in addition to hormone therapy. So that is relatively new data that really hasn't been, we didn't know about before. So chemo historically, no, but now I think will become more and more commonplace.
And doctors do that? Can they give that therapy right now? Is it FDA approved?
Can they give chemotherapy? Absolutely.
Chemo with
the hormones? Yeah, absolutely. I mean, it's not a brand new medicine. It's been around for a long, long time.
Okay, thank you. So another question I have here. What treatment or surveillance options might be available to somebody who has had a prostatectomy following metastatic disease?
So I'm sorry, could you say that again? It's a little bit.
So I have here, what are treatment and surveillance options for someone who has had surgery associated with their metastatic disease?
So it sounds like they had a prostatectomy at the time of diagnosis.
Sounds like yes.
So if they had metastatic disease, they're likely the mainstay of therapy is hormone therapy.
Okay.
And depending on the burden of disease, with the newer data that came out, they may be eligible for docetaxel therapy as well. But the mainstay for patients with metastatic disease is hormone therapy.
I think the easiest thing to measure is your PSA. I mean, in terms of surveillance. Obviously, if it's known to be metastatic, then you'll need imaging periodically to see if the tumor. So there's a PSA number, and then there's the X-ray finding. So if you have metastatic disease or the tumor has spread beyond the prostate, you have to see how you're doing. And the easiest way to do that is the blood test, but X-rays are the other way to do that.
I think it's important to await the results of your study.
Okay, so I have a question here. This was aimed towards Dr. Patel's presentation. Just wondering if you could go into a little bit more detail on some of the plus and minuses of the MRI before biopsy.
Oh, I think Dr. Deane did an excellent job of going through that. The pluses, I think there's a lot of pluses. Localizing a lesion, identifying the grade of that lesion with MRI before biopsy. I think the minuses of an MRI, it is a 45-minute scan. If you have claustrophobia, that's something you might need a sedative for, or Valium or something beforehand. Some of the machines, you can actually go in feet first now, so your head is still in the machine, but it's more, you can see the light on the other side of the tunnel. So, so there's some benefit to the newer machines that have come out. But it does require IV contrast, so you have to have good renal function as well, good kidney function. I don't think there's a whole lot of minuses in my personal or clinical opinion to doing an MRI either before a biopsy or even before treatment. I think the more information we know about the cancer, the better we're going to be able to treat it and manage it. I tell patients all the time that I think prostate cancer is one of the only cancers where we used to look at a biomarker and then randomly, blindly almost biopsy the prostate, whereas every other cancer, and if you look at breast cancer in comparison, we're getting mammograms and localization and needle localization of these lesions, whereas prostate cancer, we were checking a PSA and then really going in and just randomly biopsying. So I think for me clinically, it makes perfect sense to do an imaging study of the prostate before going in to biopsy.
I used my GPS to get here this morning. I would have never been able to find here without GPS, and I think that's what the MR helps us do. Understanding that there are limitations with those invisible tumors, limitations with the reader of the MRI. But I definitely think that it's very useful.
Wonderful. I just want to open the floor. If there's any more questions that you've had the chance to write down, just raise your hand. Someone will come through, grab a card from you. Okay. Oh.
You had a biopsy done 10 years ago, and it showed nothing, and then 10 years later you have a biopsy again. Is there any chance where the original biopsy, because of the taking the core samples out, could have caused the cancer to be biopsy?
No. I mean, that's a very common question that we get asked. Is the biopsy going to cause the tumor to spread or develop? And there's no evidence of that. I mean, you have to know what you're dealing with. If you had it 10 years ago, you would have, you'd want treatment. But no, there's no evidence to support that having had a biopsy will cause spreading or cause future tumors.
Thank you.
Okay. Another question I have here regarding the use of hormonal therapy for someone with a metastatic diagnosis. Would there ever be any instances or cases where one might recommend some form of radiation as well?
Absolutely. It depends on the situation. It depends if you have pain somewhere from a tumor site, let's say in a bone, then absolutely. I mean, radiation is very effective at treating pain, for example. We do hopefully going to be starting a study soon to say if the tumor has spread, but there's only one site of tumor elsewhere, treating the local therapy, giving hormones and radiation to that solitary site or that only site as a means by which to effectively treat that patient. So the answer is it has its role, but not always.
Okay.
And there's some evidence from institutions looking, that have done retrospective reviews, so clinical cohorts where they've treated patients with metastatic disease with hormones and treated the local primary tumor, and that's even based on other cancers, treatment of other cancer sites. Treating the primary tumor provides a benefit in overall cancer treatment. So hopefully your trial is going to help.
Primary tumor meaning prostate bed or where it's metastasized?
Usually the primary tumor site, so the prostate bed.
And then I have another question here, and this is sort of regarding the task force with the recommendations. First question is, why wasn't there an oncologist included, and will there be another task force coming soon?
The short answer is they didn't want to bias the outcome. That's what we were told. So there's no question when you treat a disease process, you're going to give a biased outcome or a biased result because you can't help but to be colored by your experience with the patients who do well or who do poorly. So I think a specific reason they did not include that was they didn't want to bias the results. But our thoughts were, well, if you're not treating the disease process, how can you really understand what patients and physicians have to go through? So, certainly that's a limitation of the recommendations that were made, and we hope there would be some change to that.
All right, well, I think that wraps up for what I have up here. Thank you all so much for coming. Thanks for your time.